Hello, my name is Maurer and I would like to invite you to my talk on the evidence landscape around the CASOne interventional radiology system. First of all, here are my disclosures. My agenda for today is to give you an overview how ablation technique has evolved over time. I would like to discuss the role of image guidance, the competition between local ablative therapy and surgery. I will discuss indications, mostly HCC and treatment of liver metastasis. Also having a look on tumor size. I would then like to summarize 4 recent publications on this topic. And of course, I would like to give an overview on our experience at Bern University Hospital. And finally, I will give an outlook for the future. First of all, I would like to show that there had been recent developments in ablation techniques treating liver metastasis and HCC. These are 2 publications that show on the left side that there was no difference in the 3-year overall survival in patients with liver metastasis of colorectal cancer that had been treated with local ablative therapy or surgery. And on the right side, you see just an example of HCC treatment. And the authors found that in HCC smaller than 3 centimeters, microwave ablation was as effective as resection. And this was also true already in 2014 when they were using ultrasound guidance. However, there's mixed reporting for HCC using RFA treatment. On the left, you see an example that there had been local recurrence rates up to 43% after thermal ablation of HCC. On the right, you see an example study of our chairman today, analyzing explanted livers, and the authors found that there had only been residual tumor in less than 3%. So the conclusion is that there is obviously a high dependency on the user treating HCC with RFA, and there's definitely a role for image guidance. This was also the topic of a recent review article that found that there is definitely a large field for stereotactic thermal ablation treating liver malignancies, and that the outcomes are comparable to surgery. I would like to give a short overview on the Bern experience in my clinic. We use the CASOne interventional radiology navigation system. So far, we have experienced this system in more than 1,000 treatments. We analyzed targeting precision. We mostly treat patients with HCC, much more than liver metastasis, and we, nearly exclude no locations. So we would treat all locations in the liver. I will just give a little bit later an overview on this. We treat up to 3 lesions per session, and each lesion can be up to 3 centimeters, which can be covered by multiple overlaying ablation zones. To give a short impression that there had been many publications since 2011, more than 20 publications, and I would like to pick altogether 4 of these publications. The first would be regarding the recurrence rate. This is an article by Berman et al. From Stockholm. And well, this is an article on 1,000 consecutive treatments in Sweden, and the authors analyzed the benefits of computer-assisted targeting. On the lower part of this slide, you see the different indications, about 50% HCC as an indication, about 1/3 for colorectal liver metastasis. The location was mostly in the liver, up to 90%, and the modality used for treatment was mostly microwave ablation, only a few patients with IRE or RFA. And targeting was performed in about 50% using the CASOne navigation system, and the rest were done with percutaneous ultrasound guidance, or some cases with some other kind of image fusion. And the key takeaway from this study is that most procedures, 96%, were without complications, and there were 10 different operators. That means that there was only a minimal operator dependency using the system. Initially, there had been a high recurrence rate, up to 30%, and this dropped to nearly 10% over time using and introducing the assistance of a navigation software. The second study I would like to focus on is by my own group. This is a study regarding the precision of navigation guidance. We included 153 patients, altogether 301 liver lesions. You see mostly HCC and also about 1/3 colorectal metastasis. And we investigated factors influencing targeting accuracy and the treatment efficacy of percutaneous stereotactic microwave ablation. And here's the most interesting result, that we had only a minimal lateral targeting error of 2.9 millimeters altogether. The trajectory length was in mean for 11 centimeters, and most of the entry points were through the intercostal space. There had been factors that had an influence on targeting precision. First of all, cirrhosis, and of course the trajectory length had a significant influence on targeting precision. This was not the case for locations that were difficult to reach, for example, in liver segments 7 and 8, and also not the case for subphrenic locations. So we were able to conclude that stereotactic microwave ablation is precise and effective, also in challenging locations. The next study I would like to summarize is on a large HCC population, which was treated in our clinic over a time period of 3 years. We included 88 patients with 174 HCC lesions, and we analyzed therapeutic efficacy in terms of local tumor control and short-term survival. Here's an overview on the different locations, and I was mentioning before, we did not have a selection bias, as this is done in many publications. So we treated all locations at the liver. You see also locations like in segment 1, which is difficult to reach, but this is on the right side. Also locations with close proximity to the diaphragm on the heart or subcapsular localizations. The key takeaways from this study are that 87% of all HCC lesions showed a complete ablation after 3 months in the 3-month follow-up with MRI, and there were only 12 lesions with incomplete ablation, which then could successfully be re-ablated. So the primary efficacy rate was 96% altogether. So we were able to conclude that stereotactic microwave ablation is safe and efficient, achieving a very good local tumor control. And then the final study I would like to show here is on MRI and CT fusion. The aim was to address difficult lesions that are not visible in CT planning scans. We took the whole patient population of 236 patients and took those patients who had an invisible lesion in the CT planning scan compared to the previous MRI scan. So we performed MRI and CT fusion to allow targeting of either the HCC or the liver metastasis to treat the patient. We did follow up after 3 months, and we analyzed the percentage of successful treatments. Here's an example. On the left lower image, you see there's a remnant of a small HCC and diffusion weighted imaging. This can also be seen in the hepatobiliary phase, but then this is not be seen in the CT planning scan. So we had to perform MRI and CT fusion, as you can see in this image. On the left upper image, you see the MRI, and the right upper image, you see the CT. These can be fused, and this allows to define a target, even if you do not see it in the CT planning scan. And then in the lower row, you see the control after microwave ablation. You see this complete ablation, and after 3 months, there was complete treatment. You see only this remnant and this defect after ablation, and finally, there is no diffusion restriction left in this right lower image. Altogether, we had 24 lesions in 15 patients, and we had only 2 patients with incomplete treatment that could successfully be re-ablated. So a key takeaway from this study is that MRI and CT fusion works, using navigation software, which allows such a MRI and CT image fusion, this allows an accurate and safe treatment for patients with malignant liver lesions, even in patients that have CT planning scans that do not show small lesions. Finally, I would like to give an outlook. Well, first of all, I would like to summarize that user navigation technology obviously works in clinical practice, as I was able to show in these studies. There have been studies on large populations with quite low complication rates. There is a low operator dependency and a very high targeting precision, as shown in the study, and navigation technology can allow very low recurrence rates. In the future, I guess there will be further software improvements regarding safety margins and also predicting the result prior to the treatment, taking all this data from previous imaging. There will also be economic considerations. And what's still missing, but more and more is coming up, to have RCTs that compare ablation and surgery. And my impression is that we will see that ablation technology using navigation will be able to show that it is at least comparable or even better than surgery in treating malignant liver lesions. Thanks a lot for your attention.